Let's jump straight into this explainer. Today, we're decoding the dense and honestly sometimes frustrating clinical reality of low back pain. We're going to systematically prove why a one-size-fits-all approach to treating your back is not only unscientific, it's actually dangerous. If you've ever been handed a generic exercise sheet or maybe tried some viral stretch you saw online only to end up feeling way worse, well, you are definitely in the right place. To really wrap our heads around this without getting bogged down, we're taking a top-down approach. We'll hit the 3 drivers of pain, look inside a disc prolapse, decode MRI and nerve roots, explain motor neuron lesions, make sense of those tricky MRI terms, and finally stack real treatments against fitness myths. Let's get into it. Section 1. The 3 drivers of pain: mechanical, inflammatory, and cognitive. We're starting by putting all low back pain into these 3 distinct buckets. This is going to give us a solid biopsychosocial framework to hook all of our clinical data onto. First up is mechanical pain. This is the big one. It accounts for the vast majority of acute and subacute back issues. It's driven by actual physical stimuli, tissue deformation or abnormal loading. Basically, parts of your spine, like the discs or facet joints, are just being physically stressed beyond their limits. The absolute hallmark of mechanical pain is that it's highly movement dependent. It worsens with specific postures, like sitting at your desk for way too long, and it reliably improves with rest or positional changes. In fact, patients usually show what we call a directional preference. That just means bending one way hurts like crazy, but bending the exact opposite way provides immediate relief. Next, we have inflammatory pain. And we're not just talking about swelling from a tweaked muscle here. This stems from systemic autoimmune processes targeting the sacroiliac joints and spinal ligaments. Now, there's a fascinating paradox with this one. Unlike mechanical pain, inflammatory pain actually worsens with rest. Patients will often wake up in the middle of the night in severe pain and experience profound morning stiffness that lasts well over 30 minutes. But surprisingly, their pain significantly improves once they get up and start exercising. Finally, we have the cognitive classification, also known as nociplastic pain. This one's wild because the physical tissues might have completely healed up, but the central nervous system, it's basically become a faulty alarm system. It amplifies totally normal sensory inputs into severe pain. Just a gentle touch or a really light movement can trigger excruciating pain. We call these conditions allodynia and hyperalgesia. The pain is diffuse, it jumps around unpredictably, and it's heavily influenced by a fear of movement, or kinesiophobia. Passive treatments like getting a massage or a standard chiropractic adjustment almost always fail here. Why? Because the issue isn't actually in the tissue, it's in how the nervous system is processing the information. Moving on to Section 2. Inside a disc prolapse, a structural breakdown. Let's see how a mechanical failure, specifically the incredibly common disc prolapse, actually builds up, ruptures, and triggers all that pain. So, let's track the physical progression of a herniation step by step. Stage 1 is the disc bulge. This is where the disc flattens under a heavy load, but that tough outer wall remains intact. Think of it like pressing down on a water balloon. Stage 2, the protrusion, is your first true herniation. That inner gel pushes outward into a specific localized spot. By stage 3, the extrusion, the structural integrity fails entirely. The inner gel actually spills out and it ends up looking a bit like a mushroom. Finally, stage 4 is sequestration. This is where a free fragment of that inner disc gel breaks off entirely and just migrates away into the spinal canal. Now, here's a crucial distinction we need to make: the difference between the severe, localized inflammation caused by a disc prolapse versus systemic inflammatory back pain. When that inner disc gel spills out during an extrusion, your body's immune system literally doesn't recognize it. It treats it as a foreign invader and launches a massive chemical attack. This highly localized, highly acidic soup of cytokines bathes the nerve root, causing severe chemical radiculitis. That's the agonizing leg pain of sciatica. But listen, this localized chemical attack is fundamentally different from a primary systemic autoimmune disease that spreads up the entire spine. That requires entirely different rheumatological care, not just rest. Section 3, decoding MRI and nerve roots. Let's zoom in a bit more and decode exactly how radiologists map the exact location of a disc herniation to predict nerve damage. This is where spinal anatomy gets incredibly precise. Radiologists actually divide the spinal cross-section into 4 zones. Essential herniation pushes straight back, which is scary because it threatens the whole bundle of descending nerves. But the most common type is paracentral. This happens slightly off-center because you have a thick ligament running right down the middle of your spine, which naturally deflects herniations out to the side. Then you have foraminal herniations, which push directly into the small bony tunnel where the nerve exits. And finally, extraforaminal herniations, which happen completely outside the canal. Where that disc material lands dictates exactly which neurological structures get crushed. Which brings us to a really vital clinical rule: exiting versus traversing nerve roots. Because the spinal cord ends higher up, around the upper lumbar spine, lumbar nerves have to travel steeply downward, kind of like a highway off-ramp, before they can exit. Let's take the L4, L5 disc level as an example. The L4 nerve is the one currently exiting the tunnel, but the L5 nerve is traversing. It's just passing by on its way down to exit at the level below. Because of this steep downward slope, an off-center paracentral herniation at L4, L5 usually traps the downward traveling L5 traversing route and completely misses the exiting L4 route. Moving to Section 4, Motor Neuron Lesions Explained. Okay, let's dive into how clinical professionals actually determine if your central spinal cord or your peripheral nerves are under attack just by looking at your muscle reflexes. Think of the spine as having an anatomical border right around the L1, L2 vertebrae. A lesion above this point affects the spinal cord itself. This is an upper motor neuron injury. It basically removes the brain's calming control over the body, so you get this spastic, overactive presentation with wildly exaggerated reflexes and rigid muscles. On the flip side, the vast majority of lower back pain involves the nerve roots below L1, L2. This is a lower motor neuron lesion. This completely cuts the nerve signal, causing flaccid weakness, a loose, floppy limb, rapid muscle wasting, and lost reflexes. Section 5, Making Sense of MRI Terms. Next, we're going to translate those terrifying, dense MRI buzzwords your doctor throws around into plain, everyday English. Reading an MRI report can induce a massive amount of unnecessary panic if you don't know the terminology. First up is effacement. If you read effacement of the thecal sac on your MRI, it sounds absolutely terrible, right? But it actually just means a bulging tissue is crowding out the protective fluid buffer around your nerves. It definitely indicates a tight fit, but it hasn't necessarily flattened or severely compressed the nerve yet. Then we have Schmorl's nodes. Unlike a normal herniation that pushes backward toward your nerves, a Schmorl's node is where the disc material pushes vertically, straight up or down into the actual vertebral bone. Surprisingly, these are extremely common and usually completely painless. They're typically just indicators of old, healed microtraumas from heavy axial loading, rather than a fresh injury driving your current pain. Next are Modic changes. These map the stress response in the vertebral bone marrow right next to a degenerating disc. The main one you want to watch for is type 1. This indicates active swelling and inflammation, which strongly correlates with active mechanical back pain. Type 2 and type 3, those are just signs of stable fatty replacement and bone hardening, essentially harmless scars from older wear and tear. And what about when the spine just naturally ages? Well, you'll often see facet arthropathy, which is basically osteoarthritis in the spinal hinge joints, causing bone spurs. Combine that with ligamentum flavum hypertrophy. This elastic jello ligament runs right down your spinal canal. As discs lose height with age, the spine settles, and this elastic ligament loses tension. It buckles inward, kind of like a deflating tire. This inward buckling, combined with the arthritic bone spurs, creates severe central canal crowding. We call that spinal stenosis. Finally, Section 6, Real Treatments versus Fitness Myths. Let's tie all these precise diagnostics directly into actual treatment protocols. And I want to expose a massive danger in online fitness culture that might literally be ruining your recovery. As you can see here, physical therapy shifts entirely based on the pain driver. If you've got mechanical pain, PT is your primary tool to mechanically recenter a disc or stabilize the tissue. If it's inflammatory, PT actually takes a secondary role to rheumatological drugs and mostly focuses on preventing the inflamed spine from fusing forward. And if the pain is cognitive, standard mechanical PT could actually make things much worse. Instead, the focus shifts entirely to cognitive functional therapy, slowly exposing the patient to feared movements to completely rewire a terrified central nervous system. This leads us to a massive fundamental clinical truth. You absolutely must separate what is hurting from why it's hurting. The source is the anatomical structure emitting the pain signal, like the L5 nerve root, for example. The cause is the underlying mechanical shear stress, the systemic inflammation, or the cognitive fear that's driving that load. Treating the anatomical source without identifying the underlying cause is literally like treating a symptom while completely ignoring the disease. Which brings us to the fitness influencer fallacy. You know the one. It assumes a single generalized exercise cures all back pain. Take the generic cobra pose, bending backward. If you have a fresh mechanical disc protrusion, this might brilliantly centralize the disc gel and cure your leg pain. But if you're an older patient whose pain is caused by facet arthropathy and a thickened buckled ligament, forcing your spine into a cobra pose will actively crush your traversing nerve roots and grind your arthritic joints together. Prescribing an exercise without knowing the specific tissue pathology, it's just guessing. We've covered a ton of ground today, the really complex interplay of mechanics, inflammation, and cognitive neuroscience that dictates how the spine functions and how it fails. So I'm going to leave you with this provocative thought. Before you try the next viral 3-step exercise for your back, do you actually know the true cause driving your pain?